Hey everybody, welcome back to our Anatomy and Physiology lecture series. My name is Neha, and today we're going to talk a bit about the hypothalamus and anterior pituitary. And the goal for today really is to introduce a few endocrine glands, talk a bit about peptide versus steroid hormones, introduce a little bit about positive versus negative feedback, and go over different axes that intersect with this very crucial regulator for homeostasis. We won't really get into the nitty-gritties of each of these because we plan to post videos in the future that will get into all of these different axes more in more detail. And so we'll just give a bit of a broad overview today, but at the end of this video, which I think is pretty cool, we're going to look at a case study that was published in the New England Journal of Medicine. And this case study will really integrate all of what we've learned today about the anterior pituitary and its critical role in secretion of hormones and kind of the downstream effects of this gland and what happens when things go wrong in pathophysiology. So just to get started today, uh, I wanted to first take a look at actually what are the constitutive linguistic components of the word hypothalamus? You might have heard in your intro biology classes in school about this critical portion of the brain called the hypothalamus, but you might never have considered, well, what does this mean, really? So the word hypothalamus is comprised of two words from ancient Greek. So the first is hypo, which means below. That corresponds to our English transliteration of hypo. And the second part, thalamus, corresponds to thalamus in English, and it means bed or bedroom or inner chamber. And this might seem a bit silly, like, okay, what does this really mean? We can take this to mean that this is the part of the brain that's below the thalamus, which in neuroanatomy is the part of the brain where sensory and motor information are relayed. It's kind of like the entrance of information in the brain, which is analogous to the entrance to a bedroom or an inner chamber, so to speak. So really, what you should kind of take away from this is that the hypothalamus is a critical area of the brain lying below this entrance for sensory information. And what the hypothalamus really does is regulates bodily functions to maintain a state called homeostasis. And homeostasis, again, is also comprised of two words. The first is homeos, which means similar or the same. And the second part, stasis, is state. So literally meaning the same state or similar state. And that's really what homeostasis is. It's this kind of physiological set point, so to speak, that the body really desperately wants to stay at. And any deviations from the set point, which naturally happen throughout our lifetime, any of those deviations will be mediated by actions by the hypothalamus. The hypothalamus will try to correct for these deviations, and we'll explore a little bit about what those corrections might be in the context of the anterior pituitary signaling. But really all you should know about homeostasis is that this is the state that the body wants to be in. And so all of the regulatory actions taken by the hypothalamus are so that the body can return to a state of homeostasis. Okay. So now that we kind of know what the hypothalamus does, we can consider what the next part of this axis is, the anterior pituitary. And the anterior pituitary is one of two lobes of the pituitary gland, which rests beneath the hypothalamus, as I've drawn here. I can maybe I can shade it. Let's see here. So what I'm shading in blue um, is the hypothalamus interfacing with the pituitary gland, and the anterior pituitary here is drawn to our left. And the anterior pituitary, as you can see, is receiving a lot of hormonal input from the hypothalamus and itself secretes a variety of stimulating hormones to other tissues and target organs and glands. So, for example, we can consider the first axis the TRH TSH axis, and TRH stands for thyrotropin releasing hormone. I can write that out actually. Let's do it in this color. So, ooh, that's a bit of a thick marker here. Let's do it like that. So here this is thyrotropin releasing hormone. And actually, one, I guess, important thing to point out is anytime you see this RH, which means releasing hormone, anytime you see that, you can be fairly sure that that hormone is being secreted by the hypothalamus. And this is a stimulatory hormone. So the hypothalamus will release this thyrotropin releasing hormone to the anterior pituitary. And that tells the anterior pituitary that, okay, we should probably secrete some stimulating hormone to get the thyroid to start secreting its own thyroid hormones. And so thyrotropin releasing hormone stimulates the anterior pituitary to secrete something called TSH, which is called thyroid stimulating hormone. And as the name suggests, it stimulates the thyroid to secrete thyroid hormones, T3 and T4, which will be secreted to target organs and signal to these organs for a variety of functions. Typically, thyroid hormones are really important for metabolism, so for modulating weight and body temperature and other things. But yeah, usually any sort of disorder involving either hyper or hyposecretion of these hormones, and we'll talk a bit about that towards the latter half of this video, but usually any of those kinds of disorders revolve around metabolic effects, so either gaining or losing weight, issues with thermoregulation, etc. And I guess you might be wondering, okay, I've written something over here about the character of these hormones. And so these hormones belong to one of two main classes of hormones called peptide versus steroid hormones. And so thyroid hormones are part of the steroid class of hormones. There actually is one other class, amine hormones, but we won't really talk too much about amine hormones in our series. But it's another class in case you're curious. But thyroid hormones are part of a class called steroid hormones. And steroid hormones, if you recall from other high school biology classes, these are cholesterol derived. And cholesterol is actually part of our cell membranes, and it's really an important part of cell membranes because it modulates the fluidity of our membranes, especially in different temperatures. Cholesterol helps keep the membrane fluid if temperatures are low, or if temperatures are too high, it allows for closer packing of lipids. And obviously, cholesterol has very important signaling properties, but really, the important point to note here is that cholesterol is a nonpolar molecule for the most part, and it rests in the nonpolar layer of the lipid bilayer in cells. And so since these hormones are derived from cholesterol, they too have this nonpolar hydrophobic character, and they too can pass through the cell membrane fairly easily without any sort of carrier or transporter. And because they can diffuse through the plasma membrane, they also can diffuse through the nuclear membrane. And so if we, let's say, draw a cell here, and we draw the nucleus here, and let's just say this is um, a thyroid hormone. This can pass through the membrane and pass through the nuclear membrane. The nucleus is actually a double membrane, so for the sake of being accurate, I'll draw it as two circles. And what can happen here, and we won't really get into this too much in our videos, but the thyroid hormone can actually bind to a receptor. Let's just draw the receptor here. And that receptor can bind to DNA. and act as a transcription factor. So this whole binding event can trigger now the transcription of certain genes involved in metabolism. And that's one of the ways that hormones could signal. Typically, steroid hormones tend to be transcriptional, um, I guess transcriptionally involved, whereas peptide hormones tend to exert their effects through non-transcriptional signaling methods. So we'll talk a bit about that when we get to peptide hormones. But usually they'll bind to a receptor, which will trigger some downstream signaling. So not exactly transcriptional regulation. But this is just one of those axes. There are many other axes that the anterior pituitary and hypothalamus are involved in. So there's something called CRH, which again, from this RH, you can tell it's coming from the hypothalamus. And this is corticotropin releasing hormone. Oops. Hormone. And like I said before, it's a releasing hormone that the hypothalamus will release to the anterior pituitary and again will stimulate the production of another hormone. And this hormone is called ACTH. Its full name is adrenocorticotropic hormone. And actually, I guess another important term that we should discuss is what are tropic hormones? So, a tropic hormone is a kind of hormone that has endocrine glands as target. So, what does that mean? So, basically, the anterior pituitary is an endocrine gland, and it signals or releases a hormone to another endocrine gland. The adrenal gland is also an endocrine gland. It too secretes hormones through the bloodstream. That's basically what endocrine means, is secreting hormones into the bloodstream, which can travel to all parts of the body. So this, when you see anything that says, if you see tropic as part of the name of a hormone, you can be pretty sure that that hormone is going to an endocrine gland as its target. And so adrenocorticotropic hormone will now stimulate the adrenal gland to produce cortisol. And cortisol will has a variety of targets. And you might have heard of cortisol before. It's typically seen as the stress hormone. It regulates quite a few processes, but I would say the most talked about or discussed processes would be regulating blood pressure, blood sugar, metabolism, and also involved in suppressing inflammation. Obviously, cortisol is not the sole regulator of these processes. We're going to talk a lot about glucagon and insulin, which are important in regulating blood sugar. And also we'll talk a bit about ADH or vasopressin, which is important in blood pressure regulation as part of the angiotensin-renin pathway. So there, obviously, all of these hormones kind of work together. There's no kind of one monopolizing hormone for any of these physiological processes, but it's still important to consider some of the processes in the body that these hormones typically have more governance over. And like thyroid hormones, cortisol is also derived from cholesterol. It's a steroid hormone. And so this kind of transcriptional control that we've explored with the thyroid hormone, we'll see something similar with cortisol. Okay. The next axis I want to briefly talk about is the GnRH, LH, FSH axis. So like I said before, again, this Rh tells you it's a releasing hormone from the hypothalamus, and this is gonadotropin releasing hormone. And this hormone, again, will prompt the anterior pituitary to secrete LH or FSH. And these two hormones, I'll write out their full names. So there's luteinizing hormone, and there is follicle stimulating hormone. Now, we're probably not going to get into the nitty-gritties of what LH and FSH do in this video. We could do a whole other video on the reproductive system, but to kind of talk a little bit briefly about their roles. So follicle stimulating hormone is important for the maturation of the follicle and for sperm in biological males and in the follicle for biological females. And this maturation of the follicle in biological females is important for egg release, which is called ovulation. And ovulation coincides with a rapid surge of LH levels in the body. And so this kind of important relationship between LH and FSH and other hormones that we'll talk about really shortly is something that we'll cover in a later video, but just wanted to give a brief overview. And I guess also it's worth mentioning that LH in biological males is important for the stimulation of testosterone production in neighboring cells called Leydig cells. But I think there's a common misconception that, FSH and LH don't have critical roles in biological male gamete maturation or spermatogenesis. And actually, it's not only in biological females that FSH and LH are important. It's important for both of the sexes. So just wanted to clarify that, but we'll get into that in another video. So, like I said, LH and FSH are secreted by the anterior pituitary to the ovaries and testes, and these organs will produce hormones called estrogen and testosterone. Again, these are steroid hormones, so they will signal in a very comparable manner to cortisol and thyroid hormone. And there are a variety of target tissues for these hormones, particularly for the development of secondary sex characteristics, which occur in a variety of tissues. Okay, so we have two more axes to go over, and then I'm going to talk a bit about positive and negative feedback. But the second to last one I wanted to talk about is the growth hormone axis. So the releasing hormone is GHRH, and you could probably guess that that is growth hormone releasing hormone, and that's secreted by the hypothalamus to stimulate the anterior pituitary to secrete growth hormone, which will signal in a variety of different tissues. And growth hormone is a peptide hormone. Peptide hormones typically bind to some external receptor, and each signaling pathway is pretty different. It depends on the kind of receptor that you're dealing with. We're not going to really talk too much about each of these different signaling pathways because there are different kinds of receptors like GPCRs and RTKs, and within GPCRs you have a variety of different signaling pathways that you could take. So don't worry too much about that, but just note that the peptide hormones will bind to a receptor on the plasma membrane, and then signaling cascades will be initiated. And from there, a variety of changes within the cell can occur, or kind of mobilization of resources to secrete to other cells. There are a variety of things that will happen. And I guess worth mentioning is that there is actually an endogenous or self-produced inhibitor to growth hormone within the body that's called somatostatin. and somatostatin is released from the hypothalamus. So just as growth hormone releasing hormone is released to stimulate the secretion of growth hormone, somatostatin is an inhibitor of growth hormone release. And this is important, right? We'll talk very briefly about regulation in a couple of minutes, but it is an important process by which the body is able to modulate the levels of these different hormones and prevent any sort of imbalance. So the last axis I want to bring your attention to today is prolactin and the prolactin's inhibitory hormone. This is slightly different than the other axes we've explored because typically what I've shown you so far has been hypothalamus secreting a releasing hormone, and then that releasing hormone stimulating the anterior pituitary to secrete a target hormone to target tissues. In this case, we have an inhibitory hormone secreted from the hypothalamus. So that will inhibit the anterior pituitary from secreting prolactin to its target tissues. And prolactin is also a peptide hormone, so again, will signal through a receptor on the plasma membrane. But just to put this in perspective, so when you have high levels of prolactin inhibitory hormone, you'll have low levels of prolactin. And when you have low levels of prolactin inhibitory hormone, you'll have high levels of prolactin. So it again, slightly different from the signaling axes that we've had above, but similar idea if you just keep this inverse relationship in mind. And so before I go on, I wanted to kind of go back and briefly talk about what these little arrows I have here are. You might not have seen this flat arrow before, but this notation is inhibition notation. So here, like I guess here and here, I have drawn arrows which signal uh, one gland secreting something to another gland. So one product is being made, whereas when you have a flat arrow, that signifies inhibition. And so in this case, thyroid hormones, once you accumulate a high enough concentration of thyroid hormone, these hormones will actually go back and inhibit the secretion of these thyroid stimulating hormone and thyroid releasing hormone. And you might wonder, why would that be necessary? If you think about this, this is actually a very intelligent regulatory move because basically built into this whole signaling pathway is the ability for the end product to regulate how much of the stimulatory, I guess, agent you have so that you don't accumulate too high a concentration of these thyroid hormones, which could have adverse effects. And so this process of regulating its own production is called negative feedback, which I've written here. So basically, when you have really high concentrations of thyroid hormone will go back into the pathway, bind to some site on an enzyme that's making TRH or something, and prevent the synthesis of more TRH and TSH, which will prevent the synthesis of more thyroid hormone. And this is true of basically all of these pathways. So, kind of switching gears, I want to talk a bit about the portal system. This is a pretty important feature of the hypothalamus anterior pituitary axis because this portal system allows for hormones to be quickly transported from the hypothalamus to the anterior pituitary. I mean, geographically speaking, they're very close to each other, but you can imagine that we have 5 liters of blood pumping through us. And if you were to secrete a very small amount of hormone into that large volume, you would end up diluting that hormone drastically. But what's really genius about the portal system is that you have a very small volume of blood that is circulating throughout the gland here. So I'm showing you arterial blood coming in and venous blood at the bottom here. And basically, instead of having your hormones being diluted in systemic circulation, in all 5 liters of your blood, you end up having just a very small volume of blood that you'll have a high concentration of hormones in, and this will allow for the hormones to be at a sufficient concentration to enact whatever signaling function they're supposed to have. And so I like to think about this in terms of tea bags. So if I have one tea bag in one cup, which holds only a small volume, as I've drawn here, you'll have a very, I guess, dark cup of tea. It'll be very saturated with the flavor from the tea leaves. But if you have one tea bag and you're instead putting it in a large glass with a lot more water than in the cup, what's going to happen is you will have a very dilute cup of tea, right? Not a whole lot of flavor will get into your tea because you have such a large volume that you're putting the same amount. I mean, assume that these are the same tea bags. You'll have the same amount of molecules, but now dispersed in a much larger volume. And so, if we consider that akin to hormones, the concentration of the hormones would be much less in the systemic circulation situation with the glass compared to the portal system with the cup. And so the whole point is we want really concentrated levels of hormones to enact whatever signaling pathways that they're supposed to exert their effects properly. And so that's kind of what's important about the portal system. There are obviously nuances to the physiology that are beyond the scope of the video, but this is kind of a brief introduction to why we have a very unique portal system, and we have portal systems in other parts of the body as well. This is not the only portion of the body where we have a portal system, but this is a very critical one given the diverse numbers of hormones and signaling pathways that both the hypothalamus and anterior pituitary partake in. So we've been talking a lot about homeostasis and kind of what the hypothalamus and anterior pituitary do to maintain a certain physiological set point. And now I kind of want to shift gears and talk a bit about pathology, which is when things go a bit wrong in the body, when we have these deviations from set point because of an abnormality in physiological processes that kind of prevent the normal return to homeostasis, as we've been discussing. So, there are kind of these two broad classifications for endocrinology disorders that I think are useful to consider here. We have hyposecretion and hypersecretion. So hypersecretion, as the name suggests, is an oversecretion of target hormone, which can be due to the fact that the hypothalamus is overstimulating the anterior pituitary, causing the overproduction of stimulating hormones to overstimulate target tissues, or perhaps it's just the anterior pituitary that's overly secreting hormones and not responding to negative feedback. And the flip side would be hyposecretion, which is where, let's say, the hypothalamus is not sufficiently stimulating the anterior pituitary, or maybe the anterior pituitary is just simply not responding to the hypothalamus. So there are a variety of ways in which the signaling axis could go wrong. But I think it's just important to think about when you're thinking about these pathways and how they are all connected to each other. Just think about ways in which regulation could be affected if you have an abnormality within the pathway. I think that's always a very useful way of checking your understanding of how these different elements are related together. Is if you have some sort of disease process, can you figure out where in the pathway this disease process might be taking place? So now I want to take a look at a case study that will really help synthesize all of what we talked about today, and hopefully you'll get to see how the importance of the hypothalamus and anterior pituitary axis is kind of exemplified through the pathology that we'll see today. So let's read through this whole thing together, a sentence at a time. The first sentence says, a 34-year-old man who has been admitted to the hospital with diabetic ketoacidosis was noted to have coarse facial features. So diabetic ketoacidosis, if you don't know, we'll probably talk about this in a later video, but essentially In this pathology, patients don't have sufficient levels of insulin and therefore begin to convert fatty acids into ketone bodies through a variety of metabolic pathways. But these ketone bodies are very acidic and therefore lower the pH of the blood, which chronically can be life-threatening. And coarse facial features, as described in the first sentence, are really defined to be an absence of fine or sharp edges, so really more rounded facial features than usual. The next sentence says that he has no known medical history, but had noted an increase in shoe size by 3 full sizes over the past 10 years and blurry vision for the past 3 years. So, because this is an adult, a dramatic increase in shoe size over 10 years in adulthood seems kind of bizarre. This would probably be more likely and plausible in a pediatric case, but in a 34-year-old man, this raises a few red flags. The next sentence says that physical examination showed a widened nose, frontal bossing, prominent lower jaw, and malocclusion of the upper incisors, findings not seen in a photograph taken 15 years earlier. Okay, there's a lot of important information here. So, the physical exam showed a variety of these skeletal malformations, and this information, in conjunction with the previous sentence, this dramatic increase in shoe size, the observation of coarse facial features, all seem to suggest that this condition involves some sort of skeletal abnormality that is more systemic because it's not just limited to the face. We seem to have some growth in the feet for an increase in shoe size. And also, something that's important is that the photographs from 15 years prior did not reveal these abnormalities. So we know that this is not some sort of congenital malformation, it's a relatively recent phenomenon. So the next sentence says that visual field testing shows bitemporal hemianopsia. And so bitemporal comes from Latin, which means both sides of the head. And hemianopsia comes from ancient Greek, meaning half without sight. So, really, patients with this condition essentially just don't have vision in the fields of vision closest to their temples, the temples being really literally the sides of your head. And usually that's because there's an issue with the optic chiasm. Maybe there's a lesion or a tumor pressing on it. But this is important information. I know it probably seems a little bit out of place because we've been talking about skeletal abnormalities, and this seems a bit unrelated. But we'll probably see how this all fits together towards the end. So just take each piece of information one at a time. The next sentence says that the laboratory studies showed a glycated hemoglobin level of 12.3%, reference range 5 to 14, an insulin-like growth factor IGF-1 level of 478 nanograms per milliliter, where the reference range is from 53 to 331, and a growth hormone level of more than 65 nanograms per milliliter with a reference value of less than or equal to 7.1. Okay, so if you consider all of these values in comparison to their reference ranges, you'll notice that, okay, the labs showing glycated hemoglobin of 12.3%, that seems to lie within the reference range. However, typically this percentage should not be as high as it is. 12.3 is actually rather high. It's far beyond the cutoff even for diabetics. It's really puts you at an increased risk for complications like further blindness and stroke. And that's because the glycated hemoglobin level is supposed to give your physicians an idea of your average blood glucose level over the past 3 months. So even though the reference range is 5 to 14, you kind of have to consider what it means to have a certain value in a laboratory study, not simply just looking at the reference ranges, but kind of knowing what the actual value means. The next part saying that the labs showed an elevated IGF-1 level. Basically, insulin-like growth factor is a hormone which bears structural similarity to insulin, but it's involved in growth, particularly in childhood. So growth hormone stimulates the production of IGF-1. So an excess amount of IGF-1 would indicate a constitutively high amount of growth hormone, which is also what the labs show. The excessive amount of growth hormone, because you can see here that 65 nanograms per milliliter far exceeds 7.1. So that excessive amount of growth hormone corroborates the patient's physical presentation of enlarged facial features and feet, and the elevated blood glucose levels as a result of diabetes could be due to, at least in part, because this obviously depends on a variety of factors like genetic predisposition or diet, or other factors. But really, the high levels of growth hormone, which antagonize insulin action, could actually result in the high blood sugar levels because insulin, as you might recall from daily life, from hearing about it, insulin lowers blood sugar. So, growth hormone, in this case, which is super high in the patient, typically antagonizes insulin action, which means it reduces the ability for insulin to do its job. Really, what will happen is that your blood sugar levels will be quite high because insulin, which typically lowers blood sugar, will not be able to lower blood sugar due to the excessive amount of growth hormone. And so, therefore, the patient's physicians were able to make a diagnosis of acromegaly. And acromegaly comes from Greek meaning large extremity, I guess is probably the best way of putting it. So, acromegaly, large extremity, that makes sense. And so, after doing some blood tests, the next logical step was to do some imaging studies. So, physicians did an MRI of the patient's head, and an MRI stands for magnetic resonance imaging. Essentially, this imaging study is really great for getting fine detail of tissues, figuring out if you have some sort of structural abnormality, if you might have any growths, and that's actually what they found is a pituitary macroadenoma. And so pituitary comes from the Latin pituitarius, which means secreting phlegm. Macroadenoma comes from ancient Greek, which means essentially a long or large glandular tumor. And that is what this is, right? This is a mass or a tumor on the pituitary gland, in this case, anterior pituitary more specifically, because the secretion of growth hormone is what's affected. And physicians did histopathological testing. And so histo comes from ancient Greek istos, which means tissue, and pathological or pathos means disease. So essentially, you take a sample of patient's tissue, the tissue rather within the mass itself to figure out what kind of tumor is this? Is this a benign tumor? Is this a cancerous tumor? What information can one get from that? And so the physicians found that the tissue comprising the tumor itself revealed that it was a somatotroph adenoma. And so, somatotroph adenomas are large benign tumors that impinge on the interior pituitary gland and result in the secretion of copious amounts of growth hormone. And that would really explain the manifestation of all of these physical abnormalities in the patient. And what's also really cool about the scan that they could do, in addition to this tissue testing, is that they could also find that the patient had macroglossia, which is an enlarged tongue, which they couldn't see through a physical exam, or they might have missed it. So the scan provides a lot of detail. It provided the physicians with information that the mass is the underlying pathology for acromegaly, and the histopathological testing of this tissue provided further information about the character of the mass that informed treatment. So essentially, the course of treatment that the physicians followed was resection of the tumor, and whatever tumor remained in the patient was treated with a certain drug, octreotide, which reduces growth and proliferation. And so ultimately, they could mediate the patient's symptoms through a combination of surgical and pharmaceutical, I guess, techniques. And this puts into practice what we've talked about today about the importance of the anterior pituitary in its regulation of secretion of hormones. So in this case, the hyper secretion of growth hormone caused this pathology of agromegaly, and really the hypersecretion was due to the fact that there was a mass impinging on the gland, causing this excess secretion. And so I encourage you all to kind of try to take a look at these case studies. It doesn't have to necessarily be published in the New England Journal, but you can look at different journals and consider how what you've learned about anatomy, physiology, signaling might inform clinical practice and how you interpret a case and how you interpret the kinds of steps and logical steps that physicians make in pursuing a course of action, how they'll take different pieces of information and use that to come up with a diagnosis. And if any of you have questions, please feel free to drop comments below and also can send us an email through the contact form in our website. And that's basically it for today. And we'll see you in our next video on the posterior pituitary. Thanks.